Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, here we are. We're going to look at ITP, which is Idiopathic Thrombocytopenia Purpura.
There you go. Well done. Well done. I wasn't going to get you to say it, but you're welcome to have said it.
Yes. And now can you please explain to me what that is?
Well, let's pull apart the word. So, we'll put the definition. Idiopathic is we don't know the cause. So that's a medical term for pretty much question mark. Thrombocytopenia refers to platelets. So, and penia is low. So thrombocyto is platelets and penia is low. And then purpura refers to an actual clinical sign, and this is little blotches, look like bruises, but it's bruises over the skin. And so this is ITP. This is idiopathic thrombocytopenia purpura. And again, there's a fantastic article in 2011, the British Journal of Haematology, written by Roberto Stanzi and Adrian Newlin about the historical perspective, and I've relied heavily on this the information, because nothing's better than getting a really well written article that you sort of here's the history. So that was a fantastic find. And look, just at the outset, there's some units that are different around the world about platelets when we measure them. Now, we measure them here in Australia of, times 10 to the 9 per litre. So we'll often refer to, there's lots. And we often refer to them as 12 or 20 or 150, but it's got that unit behind it. In America, they have microliters. It's microliters, and so that means that they refer to them as 20,000, 40,000, 50,000. So it just depends on which units you're using.
And I know you're going to touch on this later, but just for the outset, how common is ITP as something that would come over the purview of a GP?
Look, GPs will come across it, but they often won't deal with it directly. It's haematologists. So the guest that we have coming up is a haematologist, and that's who we're going to ask all the challenging questions. So, it's one of those things that people will come across. And it's a diagnosis of exclusion. So there's a whole bunch of other things you need to rule out before you say, we believe this to be ITP. And so the normal range for people like yourself or myself, there's no distinction between male and female. So if you've got a range between 150 and 450, and again, I'm not going to refer to the units, then that's the normal range for people to have.
That's still quite a range.
Yeah. It's a huge area, and some people will be perfectly normal, with 150 and 450. It's just, this is the normality of the population.
Right.
So, and look, low is anything below 150, but when we start to get worried about it is when it's between 20 and 50. And this is when the people are at risk of bleeding. And if we get to critical levels, we're talking about less than 20 and less than 10. And that's when we start to get very nervous about this, because from a medical perspective, they've actually got a lot of risk of bleeding and just spontaneous bleeding. So if you've got someone less than 10, that's when you go to hospital, because you need to find out or get a replacement or whatever the cause for it. Again, the role for platelets is one of those things that it's involved in clotting. Now, I think that's known pretty well today.
Even I know that.
and that's the thing. We know about that. But look, this wasn't always the way. In fact, it was really late that we learned what platelets did. And, we've got references. The reference of purpura is Latin, and it means purple. And, it also comes through Greek, and that's associated with porphyria. And so there's an association with the Mediterranean sea snail that has a reddish dye that comes out. And so this is sort of the purpura, is that reddish appearance. Hippocrates and Galen refers to these red eminence and spots, but they associated it with pestilence fever, so that was plague. And again, it can have that association. It's probably nothing to do with ITP. So when we start to feel or see the real references, we have to go to Avicenna, who's a Persian physician. He wrote a 14-volume canon of medicine in 1025, and he refers to this chronic purpura. Now, it doesn't go into a huge description about it, but we go to 1556, and there's a Portuguese physician, Amateus Lusitanius, and he refers to dark macules appearing over the body, and these people having bloody discharges, but no fever. But the people would spontaneously recover from these. So that does actually fit with our understanding of ITP.
It also fits with idiopathic.
Well, that's right, yeah. We don't know what happened, we don't know what caused, and then we don't know what resolved it. So, and then, in 1658, we've got Lazarus de la Rivieris, and he was a physician to the King of France, and he saw these purple spots, and he thought they looked like flea bites, and he noted that the Italians call these petechiae. So we also use these language today, purpura and petechiae, but they believed it was due to the thinning of the blood. So, but here's the thing: it's interesting because platelets wouldn't be able to be seen until the 1800s because we didn't have microscopes that were powerful enough to see them.
Yep. And
so anything was just guesswork. What was causing this? They would have known. And so one of probably the most influential in this area is Paul Gottlieb Werholf. And he's a German physician. And in 1735, he wrote a classical description of ITP. Now, this was what he called was morbus maculosus hemorrhagicus. And this is a description of a 16-year-old girl who had recently had an infectious disease.
An adult girl, robust, without manifest cause, was attacked recently, towards the period of her menses, with a sudden severe hemorrhage from the nose, with bright but foul blood escaping together with a bloody vomiting of a very thick, extremely black blood. Immediately there appeared about the neck and on the arms spots, partly black, partly violaceous or purple, such are often seen in malignant smallpox. The sudden loss of strength and the sufficient singular characteristics of the spotted hemorrhagic disease being known to me, of which indeed there is only little discussion in medical writings, we forbade venesection.
So ITP is sometimes referred to as Werholf's disease, because this is the first classical description of someone who is clearly having issues with bleeding throughout their body, on their skin, and even from vomiting.
Their nose.
That's right, epistaxis. So this is clearly a bleeding issue, and this is what they're describing. And we have Robert Willan, who is an English dermatologist in the 18th century. He wrote a book on cutaneous disease, and he describes these, classified purpura. So he tried to put them into different categories, and he put it into simplex, hemorrhagic, urticarial, contagious. Now, the one that probably fits the most is simplex, we would recognise today as ITP, and this happened most in women and children, and there is a description that he provides.
The petechiae are diffused chiefly over the arms, legs, breasts and abdomen. They are largest on the legs, though seldom confluent. The cause of this disorder is a sedentary mode of life, poor diet, impure air and anxiety of the mind. In the treatment of this disease, we should recommend moderate exercise in the open air, a generous diet, and the free use of wine, Peruvian bark, and vitriolic acid. Without air, exercise, and an easy state of mind, the effect of medicines is very uncertain. Of this I had a sufficient proof in the case. Can I just say, I want that, doctor?
Well, and again, just to reiterate, they wouldn't have known what caused it. And this leads us into 1800s when they did start to recognise that these platelets were in the blood. Now, in 1842, we had the French physician Alfred Don. Now, he noted that blood was composed of three components: erythrocytes, so the red blood cells, leukocytes, which are our white blood cells, and what he called chyle. And this was sort of what we would say today is a milky substance. So he's putting it into lymphatics. But people starting to guess about what these platelets are in the blood. In 1865, we got Max Schultz, and he thought the platelets were dust of the blood. Oh. And so people are trying to guess, but as we'll come to, it's actually quite hard to work out what platelets are and where they come from. Now, the term is actually from an Italian pathologist, Bizzozero. Now, he thought platelets were their own cell line, so they weren't related to the other blood cells, but he didn't know the origin. And it wasn't until the 1990s that we did get the link, and this was from Boston pathologist James Homer Wright, and he was studying feline bone marrow at the time, and he said these large cells, these megakaryocytes in the bone marrow, were where the platelets came from. And he thought that the platelets were fragments of the megakaryocyte. And the whole point behind that is this is a really big step in understanding blood, because the megakaryocyte is unique. How a cell breaks off a bit of itself to becomes a functioning unit to help you clot your blood. And so no other cell does that. And, I even put it on Twitter and said, look, does anyone know any other cell that behaves like this? And someone said, fungi could. But again, that's not really quite in the, in our own body system. So it's amazing, and it's quite a leap of understanding and knowledge that we were able to work this out. And so we now know these days we have a blood clotting issue, so you can have a quantitative problem with platelets, you can have a qualitative problem with platelets. And so this was our starting to understand that platelets are important in blood clotting. And so, but this then brought around what we would say is the ITP controversies, because then people started to say, well, if they're associated with platelets, how are we losing the platelets? How are these people getting the disease? And we have Ernst Frank in 1915 was saying, well, maybe it's because the megakaryocytes, the things that produce the platelets, have impaired production. And so they don't make good platelets. Therefore, you get bleeding from them not making enough. And then we have, George Minot in 1915, same time. They ended up doing transfusions, but finding transfusions, the platelets didn't stay around. Oh. So you couldn't really replace them in these patients. And so that didn't work. So he thought the platelet destruction was due to, quote, some reaction, end quote, and thought there must be some sort of poison in the blood that is actually killing them. And the interesting one we've got is Paul Kazelnissen, and he was a medical student at the time in 1916. Now, he proposed that ITP was due to destruction of platelets in the spleen. Oh. And now, just being a medical student, he actually persuaded his tutor, who happened to be by the name of Professor Dr. Scholifer, to say, okay, take out the spleen in a patient. And he did. There was a 36-year-old female who had what we would say chronic ITP and purpura over their skin, easy bruising, nosebleeds, so epistaxis, and heavy menstruation. And he convinced the professor to take out her spleen.
Isn't this wonderful?
Well, I'm clearly encouraging a medical student. And not only that, the purpura resolved. The patient's platelets went from 2 to 500.
Wow.
Now, the problem is they did this on 2 subsequent patients, but they only got a transitory increase in platelets, and then it went back to baseline. So
it wasn't the spleen.
Well, it was in the first patient, but then in the second and third, It was more complex. And this is where you start to get, people doing experiments. 1938, Trolland and Lee, they did an extract of a spleen from a patient who had ITP, and they injected it into rabbits. And they got a rapid loss in platelets in the rabbits. But again, it recovered. So again, it's trying to get this understanding. There was 1946, Demeshek and Miller, and they proposed that maybe it's because you've got reduced megakaryocytes in your bone marrow and reduced platelets. But the problem is, we know today as well, and they would have been able to do the experiment then, is that patients with ITP actually have normal amounts of megakaryocytes in their bone marrow, if not increased.
Right.
And this is why you can understand people are trying to grapple with how is this disease manifesting, how is it being caused. If you know the cause, you can manage it, and then you can get them into normal platelet territory. So it was a bit of a challenging time. And what the last one, where Demeshek and Miller ended up finding, is, of course, the megakaryocytes were increased or the same. So then they concluded that maybe it's an impaired production problem. And they found that about a third of the patients had evidence of impaired platelet production. So how is this all panning together? It's showing how complex it is, how disease. Some patients, the splenectomy worked and some it didn't. And so they sort of worked out that, okay, maybe the spleen has something to do with it. As we're going to see, in 1951, there were two heme fellows at the Barnes Jewish Hospital in St. Louis in Missouri who were about to put the eye into ITP.
Travis Brown, you left us with a cliffhanger. Please resolve.
So we have two haematology fellows, and this is 1951. And their names are Dr. William J. Harrington and Dr. James W. Hollingsworth. And they agreed to an experiment. And the experiment was they were going to find a chronic ITP patient. They were going to find out their blood grouping, matched blood group. And whichever of them matched of that patient, they were going to transfuse 500 ml from the patient to themselves.
Oh.
And then monitor their platelets. So they were able to find there was a middle-aged woman who was admitted to Barnes Jewish Hospital for bleeding. She had chronic ITP, and she had previously had a splenectomy. And she agreed to take part. Now, if anyone medical is listening to this, this is really quite strange, because a patient who has been admitted to hospital for bleeding has agreed to donating blood, which would also be, a problem for them bleeding as well. So
wouldn't it be easier to collect the blood in that case?
Well, no, it's already, that's the problem. You need to actually be able to get it to transfuse it. It will already be, activated. Yeah. So here's the thing. So it's quite an unusual first step in any event. But the patient agreed and gave a blood donation. Now, the matched group matched Dr. William Harrington. So at the time, the platelets of the patient was at 5. So that's really
that's very
low.
low.
Yeah, exactly. So it's another weird, a patient who had platelets 5 agreeing to to donate blood. Dr. William Harrington, platelets was 250.
Okay, so he's in the good
He was
range.
in good. Yep. He had a bone marrow before the experiment was to proceed, which was normal in every respects. It was normal cell lineage, normal megakaryocytes. And then he had the 500 ml blood transfusion, which went forward and was unremarkable, received that. Mm-hmm. But within a few hours, Harrington had a generalized seizure.
What?
His blood test at the time, his platelets went from 250 to 10. And he was fortunate. In a few minutes, he recovered spontaneously from the seizure. But over the next 3 days, he got the petechiae, he got the skin bleeds, the purpura. He had gum and gingival bleeding. He got epistaxis, so the nose bleeding. And he had mucosal and rectal bleeding. And so they were very concerned about him having an intracranial hemorrhage. So clearly with all of this, he was in hospital, and they got him to sleep upright to reduce the intracranial pressure so that he didn't get that. And then, fortunately, after a week, his platelets returned to normal. And so their theory was there must be some factor in the ITP blood destroying the platelets. And it was quick. And then, amazingly, they decided to extend this experiment.
Oh, God.
And they got volunteers from the faculty and staff and patients to participate, and they got 26 patients' blood.
This is before the days of medical indemnity, I'm sure.
It boggles the mind to think that you've got an experiment that someone became very sick and let's do it again. And so, but interestingly, of that experiment, when they got 26 transfusions, only 16 of them induced low platelets, thrombocytopenia. So about 60%.
Hence the benefit of having a bigger sample, because you can't make a decision based
exactly.
on...
So, maybe they did the right thing. But look, it was just one of those things that this isn't as straightforward. So how can some people have an effect and other people not? And so it just wasn't platelet destruction. And what we know today is that chronic ITP is also what we say T cell involved, so a T helper 1 disease. So we understand that chronic ITP is a combination of increased platelet destruction as well as inadequate production. But we also know that megakaryocytes are targeted by T cell lymphocytes, and so this results in ineffectual production. And so ITP in the younger age brackets affect women, more the younger women, but as they get older, there's no gender disparity between them. So we now, looking at it, yes, it's actually autoimmune, and so we get accelerated platelet destruction. There is inhibit production, and we don't know the cause. We know it's antibodies. We know that the body's producing things to destroy the platelets and impair synthesis, but we don't have a good grasp of why that's happening. And so, the primary ITP is 80% of the cases. So we don't know the cause of that amount. And, the hallmark of ITP is antibodies. And, sometimes it can be just a single glycoprotein, and sometimes it's multiple glycoproteins that are being targeted. But we can only detect antibodies in about 60% of these patients. So that's probably more of our problem, not that we're not sensitive enough in detecting them, or we don't know what the antigen is they're actually targeting. There is the other part, which is secondary ITP, and this is often associated either with chronic disease, things like CLL, or SLE is the main one, but associated with other infections, HIV, hepatitis C. We know that children get ITP, and this is most commonly associated secondary to infection, but 80% of them recover within 6 to 12 months. And there are some rare instances where children get ITP from, vaccinations, but again, responds well to treatment in those instances. So, looking at this, we're looking at, when do we get worried about things? We get worried for bleeding in these patients. And so, you've got severe bleeding. So if patients drop, 20 grams per litre of blood, they're having a significant bleed. When we get to critical bleeding, that's when it's really concerning, and this is when they become hemodynamically unstable. And in critical sites such as, the brain or the spine or the retroperitoneal. So this is when it's critical level hospital under specialists and really trying to stop it. So.
All right, well, let's get ready for Dr. Nick Myles, who'll be joining us shortly. And just one quick footnote. I know that you're a doctor. Can we not do self-experimentation? I can see this podcast developing in that way. I'm just ruling that out right now. Nicholas Myles is a general haematologist who consults in both the laboratory and clinical setting. He holds a position as Senior Lecturer at the University of Adelaide, is widely published author, and conducts investigator-initiated clinical trials through the Northern Adelaide Clinical Trials Unit. He works for Adelaide Oncology and Haematology, as well as ClinPath Pathology. His specific interests are in diagnosis and management of thromboembolic diseases and bleeding disorders. Today, Dr. Myles is our guest on This Medical Life. Welcome.
Thanks for having me.
Nick, how common is ITP?
Yeah, so ITP is a fairly rare disease. If you look at the incidence of it in countries like the US and the UK, the incidence is sort of roughly reported at around 3 in 100,000 people per year. So a fairly rare disease, and I guess in terms of prevalence, at probably a rate of about 1 in 10,000 all up. These numbers, though, are for more severe forms of ITP or ITP that requires treatment. And I guess the prevalence is probably much higher than that for people with more mild forms of the disease. So a number of people with ITP will only have mild reductions in platelet counts, and certainly that's a much more common finding, and I'm certain the GP audience would agree with that it's a fairly common finding on routine blood tests. In regards to the epidemiology of ITP, I mean, there is no real sex predominance. It occurs in males and females to an equal extent. And in terms of the incidence over the lifespan, it really has a bimodal incidence. So a small peak in childhood, and then a higher peak as people go over the age of about 60. ITP, I guess, is classified as either, acute, being less than 3 months in duration, persistent being between 3 to 12 months in duration, and chronic greater than 12 months in duration. And so typically in children, you'll see, acute forms of ITP that generally resolves, but in adults, it tends to be more of a persistent or chronic disease.
Just looking at the symptoms of ITP, what are the common symptoms you find with this disease?
ITP is typically associated with what we term as mucosal or platelet-type bleeding. So this is typically bleeding from mucosal surfaces, so generally things like epistaxis, profuse gum bleeding, in women, menorrhagia, and typically sort of widespread bruising, what is classically been called as dry purpura. Other forms of bleeding, like post-surgical bleeding, can be seen as well, but soft tissue bleeding, internal bleeding, is typically not a classic feature of ITP.
Now, is there a diagnostic criteria used for ITP? Is there something that people can look at and tick off and say yes it is or no it isn't?
So ITP is a clinical diagnosis. I guess it's important to say that there's no one particular laboratory test that confirm or exclude a diagnosis of ITP. The guidelines there's a variety of different guidelines published in the literature in regards to diagnostic criteria for ITP, but the ones I use are the ones published by the American Society of Haematology. And their criteria are basically a number of clinical criteria. So the diagnosis is really based on an isolated thrombocytopenia without an alternative cause to explain that. I guess an isolated thrombocytopenia can occur in a number of conditions, but ITP is probably the most common cause. So, I guess if you see someone in clinic with an isolated thrombocytopenia, I guess it's first important to, look at the blood count to make sure that it truly is isolated. One of the differential diagnoses you need to exclude with an isolated thrombocytopenia is a DIC type picture or microangiopathic hemolysis, of which there will be indications on the CBE of that. And also reviewing biochemical testing as well, complementary to the CBE. So, typically you'd want to make sure that there's no, LFT derangement or liver function derangement. There might raise the possibility of splenic sequestration as a cause of reduced platelet count. And also looking at the LDH, which can be a marker of, microangiopathic hemolysis as another cause of ITP. In addition, it's important, I guess, to take, drug history from these patients, as a number of drugs can cause ITP. And I guess it's also important as well to determine or not whether there's any clinical evidence of an underlying autoimmune disease that might raise the possibility of a secondary ITP. I guess one of the concerns from referrers, with low platelet counts, particularly very low platelet counts, is whether or not there may be an underlying hematolymphoid malignancy. Leukemia is an example causing ITP, but generally those conditions are very clinically obvious. Often isolated thrombocytopenia will not be a predominant feature of those diseases. So really from a GP perspective, an isolated thrombocytopenia without another cause in an otherwise well patient, is going to be ITP the majority of the time.
Mm-hmm. So then looking at, you mentioned there previously that there are some people who probably have a mild, thrombocytopenia all the way through to quite some significant clinical events, the, bleeding and needing to be investigated as to why they are. Who are the patients that actually should be referred to a haematologist to sort out which is which?
I'd firstly say that if there's any difficulty in establishing a diagnosis, so even if the thrombocytopenia is only mild to moderate, I would say that it's always worthwhile getting a haematologist to review those patients in case, on the concern that you are missing something more significant. Certainly in patients where there is a concerning clinical history, so if there are B symptoms or if there is bleeding out of context of the degree of thrombocytopenia, it may be worthwhile referring those patients as well. But I guess, for garden variety or very straightforward ITP, the indications for referral would generally be a severe thrombocytopenia. So, thrombocytopenia is classified as either mild, moderate, or severe based on the absolute platelet count, being 100 to 150 being mild, 50 to 100 being moderate, and less than 50 severe. So in people with a severely reduced platelet count below 50, that would be an indication for referral in my mind. I guess in terms of treatment of ITP, the threshold for treatment is usually a platelet count of 30 or lower. So in those patients, that's a definite indication for referral because they're the sort of people who are going to require, acute treatment for the disease.
Now, do we have any good indication? Because we have seen patients before who have, platelets of 25. They don't seem to have bleeding issues as such, but then you have, patients who are 75 platelets but do have, petechiae everywhere. Can we predict who's at risk of bleeding in these patients or who's likely to have a significant event?
Yeah, so bleeding risk with ITP is somewhat fraught. It's difficult to predict, and often bleeding can be unpredictable. And the degree of thrombocytopenia is, and of itself, I guess, the main risk factor for bleeding. So, excessive traumatic bleeding typically occurs with a platelet count less than 50. Generally life-threatening bleeding is unlikely with a platelet count of above 50 unless there's been some, major trauma or surgical procedure. And obviously the risk of bleeding, is correlated with the degree in reduction below that point. Historically, we've taken a platelet count of 10 or less as being, I guess, an indication a spontaneous major hemorrhage is likely. And a platelet count of less than 10 is usually the threshold for admitting these people to hospital for observation whilst they're receiving acute treatment. However, if you look at the literature, it's not particularly high quality in terms of, the bleeding risk that you see with these patients. And if you extrapolate data from pediatric populations, the absolute risk of bleeding with a platelet count of below 10 is actually fairly low. So I guess the bleeding risk can also be assessed in terms of the comorbidities in older patients. So, patients with, major medical comorbidities, patients at risk of falls, patients who've had a previous unexplained bleeding event. Those would all be patients that would be at a higher risk of bleeding with ITP. In addition, I guess a lot of these patients, over the age of 65, who do have a lot of comorbidities and things like that, a lot of those patients will be on, anticoagulants or antiplatelet agents, and obviously that may influence bleeding risk in those patients as well if you've got a drop in platelet count that hasn't been picked up for some period of time.
Mm. So then, when considering who receives treatment, who doesn't receive treatment, what's the goals of therapy for patients with ITP?
Yeah, so I guess the goal of therapy for ITP is to maintain a adequate platelet count to prevent bleeding complications. And so again, the platelet count of 30 is sort of taken as the accepted sort of threshold for where you should intervene for ITP, because typically patients who have a platelet count of 30 or less will progress to a more severe form of, more severely low levels of thrombocytopenia where spontaneous bleeding can be problematic. I guess as well that the mainstay of treatment for ITP is obviously immunosuppression. And so, the benefit of treatment, I guess should be balanced against the side effects that can be expected, particularly with long-term steroid treatment. So I guess it's always about balancing that risk. But, typically, if you have a platelet count less than 30, that would be, maintaining a platelet count above that would typically be the goal of therapy.
Nick, if someone's had secondary ITP in the past, are they more likely to get a recurrence of it in the future?
So by secondary ITP, do you mean associated with another autoimmune disease?
Yes.
Yeah. Again, this is a sort of clinical situation that can be quite unpredictable because, as the audience is probably aware, conditions like rheumatoid arthritis, lupus, vasculitic syndromes, they can all have a secondary ITP sort of phenomenon. And I guess the one thing that, you do see with these patients is that often the activity of ITP won't mirror the underlying autoimmune disease or the activity of the underlying autoimmune disease. So, a number of patients with, quiescent lupus, may develop a form of secondary ITP. And so in these sort of patients who do get an acute episode of ITP that dissipates, they do typically, you would typically see recurrences of ITP reasonably frequently in the future. And I guess it's important that that is monitored for. Regardless, a lot of these patients do end up on immunosuppression for their underlying autoimmune condition.
Right.
And obviously that will have an effect on the activity of the ITP. But a number of patients are, a number of patients with ITP are refractory to, low doses of steroids, refractory to other forms of immunomodulation like, azathioprine or other disease-modifying therapies. And so those are the patients where you may need to look at, second-line interventions for their ITP like, IVIG or splenectomy, TPO mimetics in very refractory patients.
Nick, if we could just for a moment look at a scenario of someone with mild symptoms, let's say platelets of 100 to 110, would you recommend GPs to trial corticosteroids or just refer this to a clinical haematologist?
Yeah, so with a mild thrombocytopenia like that, if it truly is ITP, the risk to that patient of having significant bleeding is extremely low and probably not substantially different to an otherwise well person with a normal platelet count. So the role of steroids in this situation is really only, to my mind, is really only as a diagnostic test. So you would expect that the majority of people with ITP are steroid responsive to a certain extent. And so in this situation, a trial of steroids for a brief period of time might be reasonable as a way of excluding alternative diagnoses. I guess it's important in that situation, however, that a thorough diagnostic workup is being done before that's anticipated. You'd want to make sure that this person doesn't have any other medications they're on that would be causing this, any chronic viral illnesses that might be causing it, any evidence of splenic sequestration, and so on and so forth, to make sure that it truly is an unexplained phenomenon before you trial steroids. I don't think it's absolutely necessary that a clinical haematologist is involved in that setting with a mild thrombocytopenia if it's purely just for a diagnostic test. But I certainly wouldn't suggest for a platelet threshold that high on long-term corticosteroid treatment is necessary with the aim of maintaining a platelet count within the normal range.
Just finally, when we get guests like you in, we'd like to finish off by asking if there's any tips, any advice for GPs, in this case, in relation to ITP?
Well, I guess my main tip would be, try not to overthink, a isolated thrombocytopenia, especially if it's only mild to moderately low. The causes are usually fairly clinically obvious, and I think a holistic approach to these patients is important. I guess it's important that, you exclude any evidence of liver disease, look into any risk factors for that, make sure they've had appropriate screening investigations, as an example, HIV, hepatitis B, hepatitis C testing. And, beyond those simple investigations, if they're otherwise well and the ITP is truly unexplained, then a diagnosis of ITP is highly likely. So, the weird and wonderful things that cause an isolated thrombocytopenia, are rare, they are unlikely, and they are usually clinically obvious. And I think there sometimes is a bit of a fear about haematology as to, or a mystery about the diagnosis or the treatment of these conditions. And, I'd say that, it usually is fairly straightforward in most people. And in the first instance, if they're well, monitoring can be undertaken quite safely. At the end of the day, the haematologists around town do offer a very good consultative service. So, we're always at the end of the phone if you need advice.
Dr. Nicholas Myles, thanks for joining This Medical Life.
No worries. Great to be here.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a Pathnotes Proprietary Limited production.
What do you get from the Morgan Stanley client experience? Listening more than talking, and a personalized plan to guide you through a changing world.
To learn more, visit morganstanley.com/YUS. Investing involves risk. Morgan Stanley Smith Barney, LLC.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.